Good morning, everyone. Welcome to this breakfast session on Sunday morning, the last day of COSCON 21, where we have interesting talks on how ophthalmology and technology are meeting on different aspects of patient care and optimizing and developing on technology. Especially in the era of COVID-19, this whole concept has got accelerated like never before, and more of us, who were earlier skeptical about adopting, are also, whether we like it or not, we have to get oriented to this, and it is only for the better of all the people here, the doctors, the patients, and it's just to make technology is something which enables healthcare. And I'm really looking forward to the interesting set of talks that are lined up by an equally interesting set of doctors here. For starters, we have Dr. Praveen Badwali, who is known to all of us. So it is, I think time is too less to talk about all his accomplishments. He would be leading his team of doctors over the talks. The first talk, however, would be from Dr. Sheila. It is my pleasure to first introduce Dr. Sheila, followed by Dr. Praveen for his next talk. Dr. Sheila, are you ready with your talk?
Yes.
Yeah. Ma'am, Dr. Sheila, you are the head of Department of Tele-Ophthalmology and E-Learning at Shankar Nethralaya Eye Hospital, Chennai. And you have published several peer-reviewed publications in national and international journals. You've also conducted many tele-ophthalmology workshops in India and abroad to teach and train medical and non-medical staff to implement tele-ophthalmology. It's a great pleasure for us to have you here. Please go ahead with your talk, ma'am.
Thank you very much. Can you see my slides?
Yeah. Yes, ma'am.
Good morning to everyone. My topic for today is tele-ophthalmology setup and guidelines.
Ma'am, you could be louder, ma'am.
Okay. No financial disclosures. COVID has brought in a lot of change among the clinicians. They started adopting telemedicine due to lockdown and social distancing. So the government of India brought in the telemedicine guidelines on 25th March 2020, Appendix 5. The Indian Medical Council Amendment Regulations 2020. Consultation through telemedicine by the registered medical practitioner, hereafter we'll be referring to RMP, under the Indian Medical Council Act 1956 is permissible. Now the guidelines are not applicable to the digital technology to conduct surgical procedures remotely. The telemedicine practice guidelines in larger public interest can be modified by the Ministry of Health and Family Welfare. The important exclusions in the telemedicine guidelines are: telemedicine is not the answer to all problems and surely cannot replace in-person consultation or emergency medicine. Specifications for hardware and software infrastructure are not given. There is no provision for consultation outside India. The 7 elements of telemedicine practice guidelines are: is telemedicine appropriate or in-person consultation is required? Consultation, identification of the doctor and patient. It can be from a registered medical practitioner to another practitioner, or registered medical practitioner to the patient, caregiver, or health worker. Consent is very important. It can be initiated by the patient or the health worker, and it should be documented. Now, the mode of communication can be video, audio, text. If it is in real time and it's a video, it is close to a in-person consultation, but the only problem here is you need a bigger bandwidth. A store and forward like an email can also be used. Remote monitoring is also very important. Type of consultation, it can be a first consultation or follow-up consultation like a post-operative consultation, or in-person consultation followed by a follow-up consultation. It is important to remember to maintain records for history, clinical examination, and investigations. Now, patient evaluation should be done based on proper clinical judgment. And patient management, again, you diagnose, then treat the patient. Either you prescribe medicines or glasses. Now, prescription should be similar to what we do in-person consultation. where you sign the thing, the signed prescription can be scanned and sent, or an e-prescription can be generated. Now, the prescription of medicines is list O that are safe to be prescribed. On-the-counter medicine like paracetamol. List A, these medications are those that can be prescribed during the first consult, that is video consultation, or follow-up consult. It can be antibiotics, can be used here. List B is a list of medication that RMP can prescribe in a patient on a follow-up consultation, like chronic diseases, a fill-up can be done later. Prohibited list is actually narcotic and psychotropic substances. Now, the technical requirements, people following me will be discussing in great detail. I'll be just mentioning it. The minimum computer configuration which are required should be looked in. Internet connectivity should be data card to be 2 Mbps. A microphone should be used to bring in noise cancelling. Camera, a full HD 1080p. And then image acquisition should be digital imaging and communications in medicine. It is important to do joint photographic and experts group because JPEG images are smaller in size for transmission and storage. Again, the picture archival system is used for image transmission, compression, retrieval of storage. And then electronic medical records with Health 11.7, telemedicine platform, and then antivirus. Now, visual acuity testing. Again, there is a discussion following my talk. You can do it remotely, and fundus cameras are used for anterior segment as well as posterior segment imaging. Slit lamp image will not be there. Slit view of the anterior segment will not be there. Again, smartphones like Peak are used for visual acuity testing, anterior and posterior segment images. Now, teleconsultation, virtual visit, desktop and laptop, data card with 2 Mbps internet speed, mobile phones can be used. Now, telemedicine platforms, government has come up with a telemedicine registry where you can look up the telemedicine products and decide. Software for teleconsultation is Video, Skype, Google Meet. Either you can send it as a link or log in and see. In VC, you can do remote take-up of the computer. Now, teleophthalmology implementation, basic thing is you have registration, followed by clinical workup, where the cost of the equipment come in, prescription, and then data backup, and then again billing. All teleconsultation can be charged. This can be a self-setup or third-party setup. Now at Shankar Nethralaya, we have teleconsultation for follow-up of patients, filling up of drugs. And through Titan, we do a teleoptometry where the patients are examined and consulted with doctors at Shankar Nethralaya. Now, vision centers are by Arvind Eye Hospital and others, where they have a medical equipment for ophthalmic examination and video conferencing apparatus for teleconsults. Mobile phones also can be used. The mobile units, Shankar Nethralaya, we have mobile units, where this bus has a satellite connectivity. And inside the bus, we have designed a room for ophthalmological examination and video conferencing. But here, because it's a single room, only about 35 patients can be examined. The next bus, this carries only paramedical staff and equipment. There is no examination room. All the equipment are downloaded into a facility in the village and examined. Here, about 120 to 150 patients can be seen because we have different stations for vision testing, slit lamp, fundus. Now, teleophthalmology diabetic retinopathy screening by WellCare Systems. In diabetic clinics, we have a fundus camera and the fundus images are taken for diabetic patients and images are uploaded in the teleoptia platform and the ophthalmologist writes the report which is sent as an email. Now, retinopathy of prematurity screening using teleophthalmology. Here also we have a mobile van with RedCam which goes into the neonatal ICUs and patients and kids are being examined for it. Now, artificial intelligence in ophthalmology. Artificial intelligence, Internet of Things could assist and support an RMP on patient evaluation, but the final diagnosis has to be directly delivered by the RMP. Registered medical practitioners using telemedicine should uphold the same professional and ethical norms and standards as applicable to traditional in-person care. And the limitations of telemedicine has to be understood by the doctor as well as the patient. Telemedicine services, however, should be avoided in emergency care and should be restricted to first aid and life-saving measures and advice for in-person care. If patient's privacy and confidentiality has been compromised by technology breach, then RMP should not be held responsible. Thank you very much. I thank the organizers for giving me this opportunity. Thank you.
Thank you very much, ma'am. That was a wonderful 360-degree view of the entire scope of teleophthalmology presented by you. Really wonderful that you have adopted so much in your practice at Shankara. Dr. Praveen, just one quick question. We almost use teleconsult and teleophthalmology interchangeably. The two terms are used interchangeably. So could you just, quickly give a one-liner on this and a one-liner of that, so for the sake of our audience, wherein we have to segregate and look at both of them differently?
Yeah, I guess a teleconsult is any interaction that is remote. That is something that you don't have the patient physically present in your office. Could be a phone, could be WhatsApp, could be whatever. I think what Dr. Sheila spoke about is, I think, the next level of trying to remotely evaluate and examine a patient. And have to congratulate and thank Dr. Sheila for leading and actually setting the path for teleophthalmology in India much before we all saw its requirement. So fantastic work there. And also Dr. Jayashree, you as well, as a visionary who saw the requirement of something like this much before we actually started to need it.
Thank you. Thank you for the kind words, Dr. Praveen. With that, we will now go to Dr. Praveen's introduction. Like I said, it is too short a time to introduce him. Dr. Praveen, you are the Director of Technology and Communications and also Director of Cornea Institute and Institute of Excellence at LVPEI. And you are the active member of American Academy of Ophthalmology, American Society for Cataract and Refractive Surgery, International Society of Refractive Surgeons, Cornea Society, and All India Ophthalmological Society. You take a keen interest in technology and its applications in medical science, and hope that this blend will lead to delivery of equitable and excellent care and healthcare in the future. We all, I think, are of the similar mindset, and so we have gathered here. Dr. Praveen, you have devised innovative modifications in lamellar keratoplasty and involved in research projects in the field of keratoconus, lamellar keratoplasty and refractive surgery. You are an alumnus of Bangalore Medical College, our own Bengaluru, and you are MS from Guntur Medical College. You have several publications to your credit. Welcome to this morning session, and looking forward to your talk on re-imaging in remote consultation. All yours, Dr. Praveen.
Thanks a lot, Dr. Jayashree, and also thank you for those kind words. And like you said, it always is an honor to be speaking on either the Karnataka Ophthalmology Society Forum or the Bangalore Ophthalmology Society Forum, because I'm in essence a Bangalorean. I've born and brought up in Bangalore. I only relocated to Hyderabad because of work. And in fact, we have a clash in the sessions. I'm supposed to conduct a refractive surgery session at the Cornea Society of India today. And I think when it came to the choice of which one to get on, I think I chose to be on the KSOS. So to start off this session, we have, I think, a very exciting array of topics and also a very exciting collection of speakers who portray all the efforts that have gone into teleophthalmology and evaluating and making it better, at least from the LV Prasad perspective in the last couple of years or so. I will introduce the team as we go along, but very briefly, I'd like to just set the tone for what we'll be speaking about by talking about a topic which is actually quite close to my heart, and I like to call this staying connected. This is about reimagining teleconsultation and imaging of the anterior segment. And this is, again, something that we never thought about before COVID struck. And only after 2020 March is when we actually started to think about the requirement of something like this. And what I'll share with you today is something that we built over the last year and a half plus. So when you're looking at anterior segment surgeons, and for that matter, ophthalmologists as well, we are used to a number of investigations to tell us more about the patient. But when you don't have the patient present in your clinic, how do you evaluate, or how do you assess the patient to be able to provide adequate advice from the point of view of their eye condition? So all of us know that after COVID, we all trying to reduce the number of patients who have physical visits in the hospital for a number of reasons. And we thought that one of the goals that we should aim for is to reduce the physical footfalls in the hospital by at least 20%. This has a number of ramifications, not just for COVID, but also because in all of our clinics, and this is applicable to all practitioners, we will also be able to create more space for new patients to come in. And that's the goal of what we're trying to set up. So what we did in the initial version is we set up only a telecall service in the first month after the lockdown. Following this, we actually set up a second version where we involved telecounselors, and then we tried to set up appointments for patients and then tried to consult them online. Following this was our next version where we set up a desktop or a laptop enabled teleconsult service. And then the final version that we're using right now is a mobile enabled teleconsult service that we've set up in the middle of last year or so. We were also wondering how our patients were actually helped by this. And so when we did a survey, we found that 94% of patients actually seem to have completely solved their problem by the teleconsultation itself. And so we built an app on a mobile that would help the doctor also look at the number of appointments that the patients he had on that day, and be able to service the patient appointments based on certain timelines and certain settings. So when you look at the number of teleconsults that we started to do, you see that it started very small in May 2020. And during 2020, the numbers actually rose to more than about 3,000 plus teleconsults per month in October, November, and December. And when we look at the overall teleconsults, we seem to be doing about 2,500 to 2,700 teleconsults a month by about 140 consultants. So every consultant who is in LVP actually has a day and a schedule to do teleconsults. And we have done about 43,000 teleconsults in the last 18 months or so. So when we also looked at the kind of patients we were helping with teleconsults, OC is online consults. These were patients who are not always post-op patients. They were follow-up patients. So about a 50-50 distribution between follow-up. And we tried to get a lot of our post-op patients on teleconsults to reduce one of their visits. We also provided about 20% plus of our teleconsults completely at no charge, so that we make this an equitable system for everybody who wanted it. Interestingly, we have all specialties that seem to have taken on to teleconsult. Obviously, anterior segment was the most. Retina also had a significant number of teleconsultations as well, almost 1/4 of all the teleconsults in the last year or so. And we looked at the origin of where patients came for teleconsult, and we found that this was from everywhere. There were patients who were consulting from across the country. And like Dr. Sheila spoke to you, this is not allowed to be done outside the country at this point of time. So how do we actually do a teleconsult and get more history from these patients? So the components here is to be able to get a good history, because that is potentially what you have most access to. What eye is the problem in? What about the vision? What about issues like pain, redness, watering, irritation, discharge, and photophobia, to help you to evaluate what the potential problem might be. We also ask the patient to do a self-assessment from their vision perspective, far, intermediate, and near, compare the right eye and the left eye, look in the mirror or the phone, and ask a relative to describe what they see in the eye as well, to get the maximum information. And you will also see in some time that we've done a very detailed evaluation of how you can measure visual acuity on a remote consult using a smartphone-based application. And in fact, Dr. Premanandani, who's going to be speaking to us in this session, led, along with Dr. Padmaja, a very interesting study where they evaluated the different kinds of applications required for visual acuity measurement remotely on the telephone as well. Following this, we also started to collect images of patients. Initial images on WhatsApp didn't seem to be very good, but with time, patients got better and better, and they started sending us better images clicked only on their smartphones. And some of these images were so good that they could be compared to slit lamp photographs as well. But then again, these were very variable. And that was when we were wondering what we could do to actually improve the quality of imaging on the patient's smartphone. And if we were able to differentiate between infection in the cornea versus edema versus scar, inflammation versus infection, different ocular surface conditions, and also infections and inflammations of the conjunctiva, we thought that would be great. And in fact, from LVP, we also published what could be the differential diagnosis of acute ocular pain. This is available online, and a potential flow chart about what you can diagnose on teleconsult and what might require referral as well. This was also followed by a publication from the group from Arvind, Tirunelveli, where they also were able to triage patients on teleconsult and found this extremely useful as well. So following this, one of our very smart faculty members who's going to be speaking to you later on, Dr. Vineet Joshi, led building an application on a mobile phone attachment that would help us get better images of the patient as well, so we could have access to more information from these patients. And he'll be speaking to you about this in much greater detail. But what is the value of all of these systems that we actually set up? Interestingly, if you look at the value, and we've seen that by decongesting the clinics, we've created space for a 10% increase in new patient footfalls in the hospital, in addition to all the savings for the patients from the point of view of travel and also time and money. So it is a win-win situation both for the provider as well as for the patients. And this is not just limited to only anterior segment, and we've found there's an increase in the footfalls for new patients, even in specialties like retina and uvea as well. So what we did since last year is we pushed all our post-op follow-ups, even in refractive surgery, to teleconsults. And when we compared the outcomes to see if this was actually affecting the patients, we found that patients seen on teleconsults versus physical consults, there was no difference in the outcome following refractive surgery as well, showing that this is a viable method of seeing patients online. Another very interesting and innovative setup was led by Dr. Padmaja Rani, who is going to be speaking to us again shortly. And this is about setting up a system for peer-to-peer teleconsults, where patients who came to remote rural centers in villages were seen by a vision technician, and the vision technician had an online consult with an ophthalmologist sitting in the tertiary center in Hyderabad, shared images taken using a slit lamp attachment to a tablet, including some centers which also had a fundus camera, and they were able to diagnose these patients and triage them into yellow, red, and green based on the urgency of referral. And she set up a system wherein we found that in this command center, they were able to take care of 84% of patients. That is close to 40,000 patients, in addition to the teleconsults I spoke about earlier, without them having to travel to the city, which is again fantastic value for these patients from the point of view of safety and saving time. We also set up a web portal to access patient information from outside the network, and are in the process of setting up an online consultation platform for peers anywhere, so that they also can consult doctors if required about certain conditions. Now we've also launched our home care services to enable better imaging of patients with handheld and mobile devices, so that we can actually capture greater information from the patient's eye as well. So to summarize what we did, the fact is, like Dr. Sheila spoke to us earlier, remote eye examination is never like an in-clinic exam. We should understand what we can take care and what we cannot. It's very important to set up a triage system and individualize it for yourself to determine the urgency of visit. But the goal is to reduce non-essential footfall, which is a win-win situation both for the patient as well as the care provider. And it's also important that we need to realize that we can't do everything, and to collaborate with our peers out there as well, so that we can help the patient get the maximum benefit out of all of this. So I'll stop there with the initial summary of what we want to cover, and then we'll move on in the session to cover the different aspects of what we looked at in the last year. And to take us through the next segment of what we want to share is Dr. Prem Nandini. Maybe we can have a discussion at the end of the session. Dr. Jayshree, would that be okay?
Sure, that would be fine. We'll conclude with all the talks, and I hand over the baton to you from here, so that the series of talks are all covered and the speakers are introduced. So, and we'll take it up after this session and have an elaborate discussion on this. Thank you.
Perfect. So then I'll invite next Dr. Premanandini Satguram to share her experience about visual acuity assessment on teleconsults, which is probably a vital part of evaluating as well as determining the visual acuity of patients. Dr. Prem Nandini is a vision scientist who works in the pediatric ophthalmology as well as the binocular vision and visual psychophysics setup at LVPI. Areas of special interest include binocular vision and pediatric ophthalmology and orthoptics. So, Dr. Prem Nandini, if you would like to present live, or you think we should try and play a recorded talk?
I think we can try the recorded, and if it doesn't work, I'm ready for live also.
Yes. Could we?
Shambhavi, will you enable Dr. Nandini to give her talk?
Ma'am, I did not got her video.
Okay.
Right.
Then, Doctor, you can go live. Would you enable her to share her screen? Yes. There we go.
All right. Well, thank you very much to all the organizers and specifically to Dr. Praveen for giving me the opportunity to share my work here. It's titled Visual Acuity Assessments on Teleconsults. Obviously, this work is not possible without a large team of optometrists and ophthalmologists. They are listed here, and I give all my acknowledgement to this big team who enabled us to do this little project. So like in any grievance that we all go through, there are 5 stages, and COVID pandemic was no different. So denial, anger, bargaining, and as healthcare workers, we came into acceptance mode and we modified ourselves on how we want to take this and adapt further. And one of the adaptation is actually getting into teleophthalmology or teleconsult. And a survey that came out of AIOS found that close to 99% of ophthalmologists are willing to try out this mobile app-based teleophthalmology. But from the patient side, what is their willingness? And we did a small survey and we found that close to maybe 44% of people are willing to do the teleconsultation. So in this pie chart, we can see that 38% wanted in-clinic visit, but 44% were willing for teleconsult when we take together both teleconsult and a clinic or a teleconsult. Now, there are different aspects of visual functions. You can have resolution acuity, visual acuity, contrast, color vision, 3D vision, motion perception, etc. But usually the winner is always resolution acuity or visual acuity. That's the primary factor that we want to know when we ask a patient or when we look at their records. We always look for their visual acuity. So when it came to transitioning into teleophthalmology, and visual acuity would be one of the key things that we want to assess. So when I did the Google Scholar search, there were about 512 articles just from 2020 onwards. So if we do the math, in a given month, there are close to 21 articles or so that's coming out on this topic. And one thing before we started on exploring visual acuity in tele-ophthalmology mode, even before COVID came, there was a systematic review that looked at all the tools that are available online. And in this study, they found that, close to 2,000 or so tools are available, but they filtered it down, finding out which is more current, updated, available for free. They found close to about 42 tools are available. But if we look at this paper, only one actually was validated. So this became important for us to do our own validation. And that's why we conducted this study, wherein we used the Peak Acuity app for distance visual acuity and smart optometry for near. So like what Dr. Praveen mentioned, we got this paper published. And through this study, what we found was that peak acuity is more reliable. So here is peak acuity getting tested, here is smart optometry getting tested in one of our employees in our clinic. So this was the first phase of the study. Here are the Bland-Altman plots. I'm not going into a great detail in methodology due to time, but essentially we found that when we compared peak acuity with our gold standard, which is the Complog acuity, it was pretty close to 2.5 lines or so in terms of limits of agreement. Smart optometry, when compared to the reduced Snellen chart, had a little bit more wider interval. And when we looked at repeatability, we found both Complog and peak acuity were very repeatable within maybe close to 2 letters, but smart optometry was repeatable by about 1.5 lines. So this is the coefficient of repeatability is what we are looking at. So the recommendations that came through this study is that peak acuity correlates well with clinical measurement and is repeatable. But the disadvantage is that you need another person to use this app because it needs to be tested at 2 meters. Smart optometry, on the other hand, has the advantage that it can be self-administered, the only disadvantage being that it's not as repeatable when compared to the earlier app. Now, while this is done on our own employees, very strict controlled subjects, we wanted to know how is it in the real world. So we did the next phase of the study, in which we were actually looking at patients coming to our clinic. So this was a feasibility study of testing visual acuity by the caregiver itself. And we had about 100 patients in the age range 13 to 76 years. They were accessing care from different services that includes refractive surgery, glaucoma, retina, comprehensive clinic, and cataract. And what we did was we had a demonstration video through which we oriented the patient and their attender on how to measure the visual acuity. And I'm not getting into all the details of this. This is a paper that we have recently submitted, so it's under review right now. But in short, what I would like to say is that majority of them found the app to be easy to use. And in this box plot, you can see that the comp log is the baseline measurement. So this was done by one of the optometrists, and they measured what the visual acuity is for the patient. And then we had the attender test the visual acuity on the patient under the supervision of a different optometrist, and this is their measure. And then after 1 week, we asked the attender and the patient to test their visual acuity one more time in their home setting. And then we called them and we found out what the value was. And that's what you're seeing as the peak acuity at 1 week. So we can see that pretty much these values are comparable, and that's very promising. So peak acuity is something that we can use as a home test that can be given, administered by the attender if they are oriented properly. And that's the conclusion from this study. So we can avoid some short follow-up visits for the patient if visual acuity is one of the parameters that we are interested in checking. So with that, I conclude and I thank you for your attention.
Thank you very much, Dr. Prem Nandini, and that actually is a very important aspect of expanding the scope of teleconsults beyond what we are doing right now, and we'll discuss that a little bit more once we finish all the talks. But next, I would like to invite Dr. Vineet Joshi. Dr. Vineet Joshi is a faculty member of the Cornea Service and is also a faculty member in the Center for Innovation at LVPEI. He, along with his team and especially Ashish Jain, have worked in the last year and a half in creating a systematic way by which we can enhance the remote imaging of patients by using what technology patients have in their own hands. So Vineet, waiting for your talk.
Thank you, Dr. Praveen, for this opportunity. Great initiative, Dr. Jayashree. And coming to this technology aspect, as Dr. Praveen mentioned, the history is a very important part in teleophthalmology. A great overview by Dr. Sheila, and really an impressive initiative in times when we didn't even think about that teleophthalmology will become this important in this era. Coming to the aspect of teleophthalm, when we are done with history and with visual acuity, how do we increase the efficiency of teleophthalmology? The next is to actually see the patient's eye. Now that's going to be difficult, but how do we make sure we get closer to that final outcome? You need to have good images. You need to have a good image or a video. Imagine if a patient is able to send you this from his own home, from his own smartphone, without coming to the hospital. Isn't that something would you want to see as a teleophthalmology consult, along with the history and the online visual acuity? That would add an efficiency to your clinical management and treatment. And it would also help you in triaging the patient, whether he needs urgent care or whether he doesn't, and also give medications based on seeing the fact that there is nothing going wrong in the eye, and save a lot of visits for the patient. And in return, making more slots for new consults at the base hospital, saving the money for the patient during the travel. So how did we reach here? Talk about the gold standard in imaging, the slit lamp photography. We know its problems. It's bulky and expensive, and it's difficult to transport in the peripheral centers. And in the lockdown, we got to know that who faced the brunt were the patients at having the high risk patients at the extremes of ages, and patients with with infections who couldn't come down, who needed more number of visits and follow-ups, but were stranded. So to reach to this periphery, you need a technology which is low cost and it is assistive, it's easy to use, and it should reside in those settings without a lot of maintenance. Now, how can you do that? Smartphone is an excellent tool in the hands of patient which already exists. We have amazing phones coming up day-to-day basis which have the cameras are better in technology, but they are not tuned for ophthalmic imaging. The optics, the focus, the illumination, it is not tuned for close-up of ophthalmic microphotography or macrophotography. It is mainly for a distance photography, like a scenic view, or the software is tuned in such a way, or it's intuitive for a distance photography. Now, how do we bridge this gap? So as Dr. Praveen mentioned, we conducted a small survey of, because during the lockdown, the patients wanted to reach to us, but they couldn't. So they tried to capture the images of their eye and they sent to us. So we analyzed these images and we found out that patients are trying to tell you a story, but they don't know what exactly the doctor wants to see. So most of them lack the clinical frame of interest. There was an inherent shake, the loss of focus in the images. So it used to blur out, you cannot see the details. There was lack of illumination, as you can see in the third row, that you can see the eye, but you actually cannot see anything inside it because the illumination is so poor in the area where you want to see the details. And the magnification was poor in a 44% images, which was basically that the image used to grain out when you zoom them to see the details. As a result, more than 80% images were not suitable for clinical decision making. To add to that, there are the variety of smartphones that you have. It's very difficult to gauge what quality of image they are sending to you. So basically, this highlights that you need a universal solution which can fit on all of these smartphones and standardize the quality of images. There are some attempts in the international markets which were designed for smartphone-based ophthalmic photography. As you can see in here, there were 4 products, one in Japan, one in New Zealand, and one from China. Now, these were trained for doctors or trained technicians who know the use of slit, who know which area of the eye to focus on. But these were not designed for lay people or patients. Now, we are trying to find a unique solution where we are trying to get the quality of image as good as a doctor needs to see these details, but in the hands of patients who need to be trained in that manner to get that quality of image. Now, how do we do that? This technology has to be simple so that patient understands it, and this technology has to be good enough and intuitive so that the patient is able to deliver it to the doctor the way he wants it. So we were trying to analyze the quality of images clicked by patient's smartphone, our technology, which we are calling it as Grabby, and the slit lamp photograph. And we were trying to consider the cost and standardization parameters when doing this process. And thus the concept of Grabby was born. Hardware plus software, a teleconsultation solution for anterior imaging using smartphone. And to simplify this, what we achieved with that was we compared it with the gold standard slit lamp photography. The first row and the third row are the images of the eyes captured using Grabby, and the second and fourth column are the images captured using slit lamp of the same eye. Now you can see that we are getting closer and closer to the details that we want to see. And these details are good enough for a doctor to make a decision. As you can see, there was 53% acceptance to make a clinical decision and up to 88% to actually triage the patients. We published these findings in a seminars in ophthalmology, and the way we went about it is we made this universal clip kind of a device which fits on a smartphone, and the distance of which is calibrated such that it will fall in the focal length of most of the smartphone cameras. And this works in sync with the app. The Grabby app that we have started to use is basically again calibrated in such a way that it will adjust the magnifications, the illumination in such a way that the patient now just has to tap on the screen, as you can see on the right side, and capture an image of the eye and simplify the process for the patient. Once captured, the patient can select the best image and send it to you by any platform, say WhatsApp or a teleconsultation platform here, Connect Care in MBPI, which we use, and that will simplify the process and add more information to the teleconsult. We did it as an exercise, and what we realized that all those 4 parameters which I showed initially significantly improved in a set of patients, and the quality of imaging had improved, as well as the clinical decision making and the risk stratification. Although you have to put in a lot of effort to make sure that the patient sticks to the protocol of capturing these images, and this can be done from the back end by training a team to put in this perspective. The first image that I showed you of the patient was actually where we trained his son to capture the image after a transplant. He could not travel to the hospital for 4 months, and we saved 10 visits for him, and he's doing pretty well. Another child with same example where she had microbial keratitis during the lockdown, could not follow up. We trained her father using their own phone, because they know how to use their phones much better than anybody else. And they were able to send us a series of images where we could manage this ulcer pretty well. Not just that, some high-risk patients or like mentally retarded children with keratoconus who are not cooperative, we even handed the device to them, and their patients were more comfortable around with their parents, and we could identify the pathology for them using the same concept. It's very easy. Doctors need not spend a lot of time in training for this. It's actually, you can have a staff well trained and they will do the job for you, and it can be fit into the existing system of private practice as well. Going ahead, we look forward to add artificial illumination and the blue lighting as well, which is improving the quality of imaging even further. Most of the image clarity depends on the quality of the smartphone camera, but we are trying to standardize this process so that we can bring into picture another element of AI. Now you can see the quality of imaging has improved to this extent. You can see a loose suture at 7 o'clock with a mucus strand over here in a post-PK patient. So overall, the quality of imaging has improved significantly up to 70% with of clinical acceptance. And going ahead, when we integrate it in our electronic medical record system, this will be in true sense a teleconsultation 2.0, where the EMR, Connect Care, and the Gravy will be working in sync. So in summary, it's an easy to use universal patient-facing device with a standard clinical documentation having consistency of images, and it will add value to teleophthalmology. That's Gravy to save the visit of a patient. Thank you. This is the team. Ashish Jain has been the lead designer on this team and the team that has worked on it so far. Thank you.
Thanks a lot, Vineet. And I think we'll discuss this again a little bit later. But then again, to move on to the next 2 segments, which are equally important, is we've been speaking about anterior segment imaging. But one of our young faculty members, Dr. Devashmita Maji, who is a pediatric ophthalmologist and is very, very passionate about teleconsultation, and actually, she has achieved the distinction of doing the highest number of teleconsults within LVPI in the last year and a half. And we would like to hear from her what she found as value in seeing children and in subspecialty patients on teleconsultation. Dr. Devashmita.
Thank you. Thank you, the entire team, for allowing us to share our experience. Yeah, so good morning. Everything has been already discussed about the technology. I will just share something about from the patient perspective. We know that Connect Care, this is the attitude to get connected with our patients. So this is totally an attitude of a doctor, how he or she wants to get connected with her patient. So COVID-19 has given us this wonderful opportunity to get connected to the entire network. At LVPI, you have a huge network inside the India and also outside India. But as Dr. Privika has already said, that inside the India, we were very well connected. Because of COVID-19, teleconsultation came out, and the sole purpose of this teleconsultation was to how to triage the patient. The main concept was the triaging. So we divided all the patients into 3 categories: Category A, Category B, and Category C. Depending on every specialty, we have our categories. So in Category A patients, they can be taken care solely by teleophthalmology. But Category C patients, they have to come to the hospital. The Category B patients, we can reduce the frequency of visit to the hospitals. This teleconsultation helped us to get connected to our all 3 tertiary centers, 22 secondary centers, and 234 vision centers. Because of teleophthalmology, we availed these services much more during these COVID times, and definitely our secondary centers and vision centers helped us a lot during this COVID crisis. So every department, they have their own priorities. In cornea, the category A, we see the pterygiums, pinguiculas, or dry eye, corneal scars, follow cases of conjunctivitis over teleconsultation who never came to the hospital for the follow-up visit. But in cases of keratoplasty, the follow-up visits frequency were reduced by doing the vision assessment and the intraocular pressure measurement at the nearby vision center or the secondary center, and they have to share the reports with us. Similarly, for cataract, the patients most benefited with the cataract surgery patients where the post of 1 week and post of 1 month follow-ups also, we don't ask the patients to come. At the 1 week, we give the refractive corrections, or at the 1 week, we do the teleconsultation and call them at the end of 1 month. Dr. PVK has said that many of the LASIK patients, the the phakic IOL cases, collagen cross-linking cases, depending on the surgeon's choice, they have reduced the frequency of follow-up visits of their patients, and definitely without compromising the quality of care. The vision was as good as expected when the patient attended physically to the clinics. And definitely in glaucoma, we see in the clinic many patients come only for the drops to clarify their doubts about the medications, if they have allergy for the medications. But these things can be taken care easily over a video call or over a phone call. And only for the intraocular pressure measurement, they can go to our nearby vision center or the secondary center. And from there, they can share the medical report with us. And we have also taken help from the local hospitals where they can do the HBF and share the reports with us. So by this way, we have reduced many of the follow-up visits for these patients who can be taken care locally. Similarly, for retina cases also, many surgical patients, to get a surgical appointment, to get a date for their injections, they want to come to the hospital. Here, the team of teleconsultation, they help the connecting with the doctor and book the appointment in such a way that patient come prepared with all the required blood tests also, so that he can easily avail the services, and in the same visit, he can finish off everything and return home, because they are coming from very far places. During the COVID time, these visits are very difficult for them. So this teleconsultation helped them to book the appointment. At the same time, the follow-up or post-op surgical follow-up also reduced. Yeah, coming to my department, as I belong to pediatric, my perspective was that in COVID, the pediatric and geriatric, these two groups are really affected, because their family members, they don't want to bring the children or the elderly patient to the hospital during COVID time. So here the teleconsultation helped us a lot, because most of our children, only for the vision assessment, their follow-up refractive error and the amblyopia therapy, they have to come to the institute. So these things we have taken care over the telephone. And the cataract surgery children and the strabismus patients, we need just a photography or a video call to see the ocular alignment or their extraocular motilities. And neuro-ophthalmology patients, only the MRI reports and the blood tests, those can be also taken care of over teleophthalmology, and we get them connected to the local physician where they can avail the services. At the secondary center level also, we followed the same trials principles. Now coming to my experience, as we started 1.5 years back with the teleophthalmology, my first contact was with all the lost to follow-up patients, where I came to know that in our institute also, we have so many patients where get disconnected in last few years. So with teleophthalmology, when I communicated with them, we found that they have stopped their medication, they have stopped their managements. And when the doctor started talking to them, they again started coming back to the hospital after the COVID. For our department in Odisha, we are operating the pediatric cataract for the RBSK group. They are the underprivileged population. Most of the children, they belong to tribal groups, and they don't know how to take care of the children's post-operative thing properly. Here, the coordinators from the RBSK, with their telephonic consultation, they helped us to maintain these follow-ups and to take care of the children. Because we know during COVID pandemic, post-op care for children is very crucial for the family also. And surprisingly, my teleconsultation team, they booked appointment also for the UA children, examination under anesthesia children, where during the conversation, I came to know that many patients, they were not properly aware of the topical medications after the suture removal. They don't know whom to call, what to contact if there is a redness. And many patient parents, they have not purchased the glasses also, because we know our specialty. Most of the children, they suffer from dense amblyopia even after cataract surgery. That pair of glasses is very much important. And we know during COVID time, many patients, they could not come for the 1 month and 3 month follow-up also. So these children, they were continuing their amblyopia even after a successful cataract surgery. So this post of call after UA helped me to follow up these children and to insist those parents to avail the services as early as possible. And one most heart-touching thing was about the delayed developmental milestone children, like our cerebral palsy children and HI children. We know that their parents are always in a depression. And for these children, the real doctors are the mother. We only can guide them. The real therapy was given by the mother. But during COVID time, their family suffered to such an extent that the mother has lost the motivation to do the vision therapy also. So during that time, the rehabilitation team, by continuous video calling, this continue to maintain that motivation of the mother to do the vision therapy. And at the end of COVID, when the parents come and they give the feedback that their motivation was maintained by this video call, that was really helpful for us. Many of the children were taken care only by the video call only. And during the second wave, many new patients come into picture because teleconsultation was already popular among the patients. So during this 1.5 years, I touched upon around 2,000 patients who taught me that getting connected with the patient is more important than doing a successful complicated surgery. That was more valuable for the patient when the doctor get connected with them. There are few stories where highly educated professionals, they hesitated to come to the hospital, to our department, even if they have been referred by their local physician. You need an immediate neuro-ophthalmology consultation for your optic neuritis. But he connected to the teleconsultation team. Within 2 hours, the team arranged such a nice call, video call. Then we can motivate the patient to at least come for 30 minutes to the hospital. We will take care of everything with the protocol, but we want to see at least once. And patient agreed. And ultimately, his IVMP, everything was done at his local hospital. We just guided the patient. At the end of 2 weeks, he gained his vision and his confidence. Similarly, congenital glaucoma babies, the follow-ups during the lockdown period was taken care so nicely by the doctors that at the end of this lockdown, when the child was operated, it was a successful surgery. Same thing with the retina team also, that new patients, they have win the faith of the patients who lost their faith in the local doctors, but they could believe this doctor, and at the end of lockdown, they come for the injections or the laser procedures. This is our own patient who was lost to follow, who is a one-night patient with surgical aphakia. He started endophthalmitis during the COVID time. The son could do very nice pictures and shared with the retina person. And we arranged his travel with during the lockdown period, and we could save the eye because his right eye is endophthalmitis and left eye is surgical aphakia. And he developed endogenous endophthalmitis in that eye. So at the end of the talk, I just want to say that now we have completed 360-degree circle with the help of home care team, because now our team can reach this geriatric people who have many physical ailment, though they cannot reach to us. The technology is the driver. Definitely from today's morning, we're seeing so much technology that with the help of teleconsultation and home care, vision assessment, intraocular pressure assessment, anterior segment photos, and the fundus photos, everything is helping the faculty to take a proper decision and how to fast track the treatment for the patients who need it. This is one story from an ICU. The young guy, after road traffic accident, he has multiple fractures and had to undergo surgeries, but he has lost vision in the left eye. And if we don't treat the patient in that window period, we know after that we can't help the patient. So that hospital allowed our home care team to go there, visit there, do all the assessment, fundus photos, and from our institute, we prescribed the medications, and the ICU people followed that medications. And we are yet to see the patient physically because he has a fracture, he is still in the ICU, but at least teleconsultation and home care help us to save that 72 hours of window period after a case of trauma. This is one of the retina patients after his surgery. Sorry, the video was in Odia, that's why I have made it muted. After successful retina surgery, he is not able to come for the follow-ups. So his next 2 to 3 follow-ups was done by the home care team, and the treating surgeon has took care of his vision. It was a successful surgery, and the whole family is happy that without taking him to the hospital, everything is possible because of this team effort. So now we have started for our fresh appointment patient. One of our doctors in the retina, Dr. Umesh Behra, started with his own patients who are taking fresh appointment with him. He is now first booking a teleconsultation with the patient because many of the patients are just want to come for a second opinion, or many patients, they want to book surgery with him or injections with him. So he is taking the teleconsultation and helping the patient to channelize so that the directly patient can come on the OPD day, and the next day he will be operated with prepared all the reports with all the investigations, so that the time will be cut short. And the patients who need a second opinion, he just gave his second opinion and he asked the patient, don't come. You can continue with your local ophthalmologist, no need to come. So these are the few steps where we are helping the patients, and as Dr. PBK has said, that we are helping taking new patients instead of continuing with our old follow-up patients. Ultimately, this is our aim. Thank you.
Thanks a lot, Dr. Devasmita, for that very comprehensive outline of the different specialties and the categories for referral and for teleconsultation. To round this off, all of this actually is geared towards delivering a particular value. And what is the quantum of that value is going to be shared by Dr. Padmaja Kumari Rani. Dr. Padmaja Kumari Rani is our faculty member and retina specialist at our Hyderabad campus. She is also the network head for teleophthalmology at LBPI. And she's going to be sharing with us what impact teleconsults actually will have for all of us.
So I think, thank you. I think this is an excellent session, and to round off with an impact, what teleophthalmology can create. And thank you, Praveen, and thank you, Jaya, Dr. Jaya, for this wonderful initiative and for giving the opportunity. So I would like to discuss about what impact teleophthalmology can have both in environmentally and as well as in economically. So even the first teleophthalmology project probably started way back, 35 years back, with actually a space mission. Space mission, and the Columbia mission was transmitted through to know about the effects of ocular effects on the specific gravity. So from then we know that last 35 years teleophthalmology has actually been shown to be beneficial in providing both reducing the rural and urban divide, avoiding unnecessary teleconsultation. We know that it reduces the time and as well as the money, and also reduces the carbon footprint. And most importantly, we have seen in all our talks that it has actually helped us to continue the eye care during and following the pandemic. So there is this concept of carbon zero health care system. That is how much actually just doing teleophthalmology we can actually reduce the carbon footprint savings is a very, very important thought that we should keep in mind. That this article, this systematic review by Purohit et al., they found that it actually can reduce the carbon footprint saving from 0.70 to 372 kgs of carbon dioxide emission for each teleconsultation that we perform. So let us just look at these impacts in both primary care, specialty care, and also the special situation where we had a COVID-19 pandemic. So this is an article, this is an economic impact which was done by the Arvind Eye Care System, where they actually, so the economic impact of teleophthalmology in India at the primary care. This study from Arvind Eye Care System clearly shown the cost benefits in treating corneal conditions alone, and was about 1200 INR per patient. And when you actually translate this total cost saving for the community in 1 year, it is around 1.14 million rupees and $15,000 US. And when you actually extrapolate this benefit for the community in a 10-year period, you will see that it is actually 7 million rupees and 94,000 US dollar. So at the primary level at LVP, previously as shown by Praveen, our fellows and residents are able to detect and manage simple to complex eye conditions from conjunctivitis to eye cancers. In the past year, we had 46,000 teleconsults at primary level, out of which only 84% are managed at the primary level itself. And 16% patients only required actually referral to the next level of care. When we calculated the economic impact, cost saving per patient is 1,500 INR, almost 20 US dollar per patient, and total cost saving for the community in 1 year was 60 million US dollar, 60 million Indian rupees. And when we analyze environmental impact, so the calculation is that 1 kilometer travel can avoid 113 grams of carbon dioxide emission. So you can see that the patients, when we, the almost nearly 4 million kilometer travel was avoided by these 40,000 patients, thus reducing 450,000 kgs of carbon dioxide emission due to primary care teleophthalmology. And during pandemic, we definitely integrated our teleophthalmology into regular patient care pathway, with a primary importance of reducing unnecessary follow-up visits. At least one physical visit following surgery was mandatory. And we also could even do unnecessary footfalls, avoid by just reviewing of reports, or new patients where second opinions based on the reports. This has been integrated along with the home care system. So, and a total of 40,000 online consultations took place between June 20 to September 21. And you can see that when you see the numbers, definitely the figure clearly shows that there was an increase in the number of patients using the teleophthalmology facility corresponding to the peak period of the pandemics in both October 2020 and May 2021. And when we calculate the economic impact of integration of this mobile teleophthalmology app in regular patient care pathway, at just one campus, LVP Hyderabad campus, total cost saving per patient was 5,000 Indian rupees and 69 US dollars. And total cost saving for the 15,000 consultations that happened in one campus was 79 million Indian rupees. And when we look at the environmental impact, we can see that 10 million kilometer travel was avoided with a reduction of 1.1 million kg of carbon dioxide emission. So, and along with this economic and environmental impact, we need to know that there is an intangible benefit, is also a social impact and power of teleconsults, removing the barriers of access and distance, like teleconsultation from train, or diagnosing congenital cataract, or monitoring surgical follow-up through the photographs that are captured by the caregivers. And this is a story of mucormycosis, in where a primary retina consultant was able to provide necessary advice to a COVID patient admitted in the hospital, and could provide the cost consultation with oculoplasty consultant as well, because of the cross consult app facility that is available in the app. This is a story of a limbal dermoid in a neonate, which was managed with cross teleconsultation between pediatric retina and pediatric cornea specialists. And this dashboard shows the latest numbers on e-Sanjeevani virtual patient platform by Ministry of Health India, catering to more than 36 million patients since the onset of pandemic. Similar nationwide expansion is definitely possible for teleophthalmology services as well in India, based on the evidence generated from all the case studies, that is in the modes of primary and specialty and pandemic innovations in teleophthalmology, creating positive economic, environmental, and social impact. And let us all aim for a carbon cost-effective health systems with a goal of net carbon zero healthcare system. Thank you.
Thanks a lot, Dr. Padmaja, for that amazing insight into where the value of teleconsult lies beyond the provider and also the patient as well. And I think that actually brings to an end a roundup of what we believe is the direction that teleophthalmology is headed in. Dr. Sheila John showed us what the guidelines for teleophthalmology are, and also where teleophthalmology started several years ago. And then again, we went through the different possibilities that teleophthalmology has and what it might evolve into in the future. But I think we would like to leave you with the message that teleophthalmology is here to stay, irrespective of whether COVID is here to stay or not. And thanks to COVID, this probably is a discovery that has been made ahead of its time and has also brought in more acceptability as well. So hopefully, a lot more of us will transition into evaluating and embracing teleophthalmology for our patients, with benefits for the patients, for our hospital systems, and for the environment at large. Thank you very much also, Dr. Elan Kumaran, for thinking of this session in the KOS, and also for Dr. Jayashree for being such a fantastic host and for being so kind to allow us to speak about all our experiences as well.
Thank you. Thank you so much, Dr. Praveen and team. It has been such a pleasure to listen to all of you. And I was in LVP recently, and I could see that every consultant is allocated one day purely for online consultations, and how effectively it was being done, and also documented. Each and everything is documented in such an elaborate way, and no wonder you guys are like leaders in this aspect. Not to forget that when nobody thought of it, Shankara Netralaya has thought of it, and one of the pioneers is here with us. So I really open the panel out for discussions now. One of the things that is very touching to note that you have included environment and carbon footprint in one of the talks. Recently, I was part of a session which was conducted by the International Academy of Prevention of Blindness and the United Nations Friends of Vision together. And it all talked about responsible consumption and responsible production in eye care, and how is it that we can reduce carbon footprints in our OT usage, overall in healthcare. And I think we have brought up a very important aspect on how telehealth and the unnecessary movements being cut down can really add to sustainability and environmental friendly adaptation. That's amazing to note. Dr. Dev, so nice that you brought out how retina, how pediatric ophthalm, how cornea, each department, each subspecialty can, adopt. And it is just not about simple things, ocular surface. Dr. Praveen, would you like to tell us more about the GABI that you are forming? Is it autofocus enabled, or should the patient care provider actually go and he should be intelligent enough? I'm interested to know more about it.
The current version, I think Vineet probably is better suited to speak about the GRABI as of now, and he deserves to, because he's been one of the driving forces behind it. So Vineet, would you like to elaborate?
Yeah, thanks, Dr. Jayashree and Dr. Praveen. So the currently the app has an embedded autofocus, and the patient, yes, he will have to tap on the screen, and that's it. I mean, the focus will adjust and it will capture the image. We are looking forward to improvise this app even to an extent further that will actually improve the quality of imaging, and the effort from the patient side would remain minimal as possible. Because if you try to do this on a normal phone, you will have to figure out a custom magnification, then adjust the illumination, and do a lot of settings, and which will differ from phone to phone. So that barricade is gone. All the patient has to do is plug in the clip, start the app, keep it at the correct distance, and just tap on the screen. The flash, illumination, or focus will take care of itself.
So why I ask this is I'm working currently with some retinal cameras, and there automatically when it gets focused, there is a green zone which comes up, or if it is not focused, then it's a red. In that way, I think that's subjective thing, because now it's not even paramedics, it's the patients and their attenders at home who are, and there is no question of learning curve. They have to do it instantly in
So
whichever scenario.
Yeah, so that's where training becomes really important. The first training to show them what is the ideal image that we want and how you can do it with your own phone. And that is how the patients do it. What I have seen is that initial first two images, the patient still needs a little handholding, which is where you need to have a back-end team to help them. But once they get one image right, they do it continuously by themselves. They'll keep sending images every week, every month of the same quality. And it just improves.
Yeah. So currently, I think wherever we are using technology, there's a lot of like hybrid model that is happening where you do need human interface. the whole idea is to get closer and closer to how, we can minimize human interface, and it directly is between the patient and the doctor. Like even in home care, there has to be, if it's a geriatric patient, then there has to be a caregiver who comes in between and, takes image or something. So if the more smarter it is, or the more user-friendly it is, probably an 80-year-old himself or herself can take their image and send, I'm just talking a little futuristic, but probably that is where we are all trying to get to. Is there anyone else who would like to ask the panel something want to know about them? I can see Dr. Sharavana here, Dr. Karishma is here.
So maybe we have several other interesting talks on teleophthalmology and technology as well. Maybe in the course of the meeting, we probably will have questions generated. We probably should.
Sure, let's proceed.
Yeah.
Thank you. Thank you once again, Dr. Praveen and others from the LVPI and also from institutions outside to have contributed to this first round of talks.